It's my pleasure to welcome you all. Day 3, Conquering Coronaries. Today we focus mostly on physiology of coronary interventions, and we also have something on complication management and prevention of complications. Today we have two keynote lectures. The first one by Dr. Praveen Chandra on FFR, and the second one is by Dr. Niels Johnson on FFR. We also have a live case on physiology and imaging from Maitra Hospital. And following that, we have case presentations, which is going to highlight the usefulness of physiology imaging as well as complication prevention and management. Now, let me take this opportunity to introduce the moderators and expert panel. To start with, we have the most senior interventional cardiologist in our country, Bahulen sir. He was the head of the Department of Cardiology at Trivandrum Medical College, and presently he's a chairman and head of the Department of Cardiovascular Center at Anantapuri Hospital. We have Padmasri Dr. Praveen Chandra. He's the chairman and interventional cardiologist at Medanta Medicity at Gurugram. And along with both of them, we have the international faculty, Dr. Niels Johnson. He's associate professor of cardiovascular medicine at the University of Texas. Let me also take this opportunity to introduce the most senior expert panel, Dr. M.S. proceedings. Let me request Bahulen sir to take over and conduct the proceedings.
Yeah. So, shall I start, Dr. Deepak?
Bahulen sir, we didn't hear you. You were muted. Could you please?
Yeah, okay. Can you hear?
Yeah, I'll just, okay. Thank you, Deepak, for this introduction, and congratulate you on organizing this very, very wonderful program. And as you have introduced the speakers today's program on basically on coronary physiology, I invite Dr. Praveen to go ahead with his first topic. He's going to cover the use of FFR in special situations like osteal diseases, especially aorto-osteal diseases, bifurcations, and serial and tandem lesions. Dr. Praveen, please.
Can you see my screen?
Yes, sir.
Yeah. Okay. Okay, just a minute. I think the slides are little. Have to go to the. No, this is not right. It is progressed automatically. Okay, fine. So, thank you very much, Dr. Deepak and Dr. Bahulian and everybody else here for this wonderful symposium, which you have been doing for the last 3 days, and I'm sure a lot of learning. So today, I'm going to share with you about the use of FFR in different scenarios, and now we have so many brothers and sisters of FFR today, the IFR, the RFR, the DFR, the QFR, the CFR. So I'm not going to discuss everything, but certainly as a generic, I'm going to discuss about the use of physiology, I must say, in different situations. So today what I'm going to discuss with you is not only FFR. It is, one can, take it towards RFR or the IFR. And I'm sure everybody is now aware that two big trials came up just recently, the Define Flare and the Sweetheart trial, and on the IFR, which showed that IFR and FFR are almost same, and they can give equivalent results. So in today's lab, and we have all these kind of patients coming to almost every lab. So it is not that, complex patients have to go to a center which is more experienced and more established. All these patients are all mixed up, and we have to make our judgment and decisions in each of these cath labs where the procedures are being done. And the good thing is that now physiology is usable in almost every cath lab. It can be done, and that's why I, kind of, it's my recommendation and also my hope that every cath lab should have physiology while intervention is being done, because these kind of lesions, especially the complex multivessel disease, multiple serial lesions in one artery, diffuse coronary artery disease, focal osteal lesions, and previous MI, non-STMI, and acute coronary syndrome, all are in a mixed bag. So we have to take the decisions whether to treat that lesion or to leave that lesion, whether to use one stent or to use many stents, and whether this patient is really a good candidate for a bypass surgery or just medical therapy should be good enough. All these decisions can be taken after an angiogram if we use physiology or one of these techniques of either the hyperemic indexes like FFR or the non-hyperemic indexes, which is IFR and RFR, and sometimes even QFR, which is measuring physiology by just doing an angiogram. And I'm sure you all will be glad to know that we are going to be having these QFR, and maybe some labs have it now, but in India it is going to be available. And there is some data now comparing QFR to RFR and the FFR. So what exactly it is, and everybody knows this, that the coronary pressure in a normal epicardial vessel is like this, and when there is a lesion, it becomes like this. So anything beyond a significant lesion will remain like this. So basically, we are just measuring this, and when there are multiple lesions, then what happens? There is a gradual decline sometimes, and at times there may be no decline, as you can see here in the circumflex. So we have to figure out in patients with multiple lesions in same vessel or different vessels, whether we want to treat all or some or none. So that decision can be taken very easily if we use judiciously the physiological techniques, and this is the FFR or the IFR. So let me start with the acute coronary syndrome thing, because this is something which we do it day in and day out, and almost 40% of our patients who are being treated in India, according to the the NIC registry, are acute coronary syndromes or acute MIs. So this is a very big chunk of patients where we need to take the right decisions. And the first question becomes whether it is reliable in the setting of MI. Certainly it is. And whether there is any change because of the microvascular stenting, not much. And if we serially follow these patients, we do FFR now and do FFR in 30 days or 3 months, it will remain constant. That has been shown very well, that this, and all, of course, this is dependent upon the amount of myocardium which is being supplied. So FFR appears to be accurate and safe in the setting of non-STMI and acute myocardial infarction for the non-culprit vessels. So these are some of the data which is available and showing that it remains unchanged between acute and follow-up phase in patients with STMI and non-STMI. So it is a safe thing to do. And in FAME study also, there were 32% of patients who had unstable angina or NSTMI. So which means it has been used for some time now. And now in patients with multivessel STEMI, what happens? There can be 3 approaches. You do everything multivessel PCI acutely based on angio or based on FFR. Or you do an intermediate setting, which is do a non-IRA stage procedure in the index hospitalization or little later by doing based on angio or based on FFR. And the third option can be that you do the revascularization based on ischemia and symptoms, and this could be a conservative approach. So all this has been studied, all these permutation combinations in these 2 big studies, the PRAMI, the civil culprit study, and of course the other combination on FFR has been studied in the dynamic premulti study and the compare acute study. So all these various options of strategies have been assessed in these studies, and this is the result of dynamic 3 premulti study, which showed 44% reduction through complete revascularization if it was based on FFR. So now this is very important, and because there is already so much confusion as to when we should do the non-culprit vessels, should we do it at the same time or should we do it later? And then came the shock MI trial showing that you just treat the acute vessels. So this I think data becomes very important, that you take the decision based on FFR and you do a complete FFR guided revascularization, as was seen from this study in multivessel disease patients who are having STMI, and look at the primary endpoint, that there was a significant difference in terms of primary composite endpoints. Now, this is the study. This was done with the Zine stent compared with angio-guided culprit only in multivessel disease patients. And in this also, it showed that there is a significant difference in terms of course, it was expected that it will be in terms of revascularization. However, there was no difference in terms of death. So this is reasonably clear that it is safe to use this in acute coronary syndrome, and we can take. And now let me tell you this thing. This is very important. This is very, very important for our own setting in India. Why? Because only yesterday I was having a session, as Dr. Hiremat was mentioning, that there are so many symposiums happening which have some good things to take all the time. And in that we were discussing that whether doing a staged procedure, maybe in the second hospitalization or second time, everybody's answer was that it becomes more expensive. In India, we have to cut down the costs. So how do we do this? I think doing it with the FFR guided intervention in the same sitting, in the index procedure, can lead to cutting down the cost and the time of hospitalization for these patients. So this is quite an interesting thing which we can adapt to our own patients. Then the guidelines, they of course suggest that FFR can be done in STMI patients, and the cutoff value remains less than 0.8. So there is no difference. The cutoff value remains same, and of course these are the different kind of criteria which can be applied in non-culprit vessels in patients with acute coronary syndrome. And in here it says that if there is an intermediate coronary stenosis, the FFR value should, if it is less than 0.8, it is appropriate to do that intervention. So now let me move to some cases, in real life cases. And in here you see this patient comes with angina. And look at this. On angiogram, it doesn't appear very significant anywhere, but there are so many lesions. There is a lesion in the distal circumflex, whether this is the culprit, or there is a lesion in the LAD, or there is a lesion in the distal left main. Which is the culprit? Who knows? So how do we find it out? I think in this, the first thing we do is put a wire inside and then do a FFR. And when we did the FFR, we found that it is 0.77. Now, which means that there is a significant lesion which is in the proximal or the ostium of the lady, maybe, or maybe it is the distal left main, almost the same meaning of that, but certainly it is significant. So physiology proved it, and this is the if you can see this, that there is a significant FFR in this lesion. So which means that we are fairly clear now, that we are not confused. So we go for imaging in this to substantiate where we have to do this, how long the stent has to be, and then look at this OCT. So before doing anything, we are doing all this evaluation to substantiate our appropriateness of the procedure and accuracy, and of course final optimization of the procedure. And here you saw that there was a very discrete lesion at the ostium of the LAD and also in the distal left main. So where things then become very simple, what we do here is we also saw that the ostium of the circumflex is okay. So we say, okay, just one wire is good enough, and a crossover stenting should do the job. There is no need to put extra wires. There is no need to put 2 stent techniques, etc. And hopefully we'll get a good result. So here we see that we just put 1 stent here, and from the left main going into the LAD, and finally check it with the OCT pullback. And these are the final outcomes. After the OCT, we do a post-dilatation because it is a kind of a slightly fibrotic lesion at that site. And finally, we got a good result. The circumflex ostium is flowing well. There is no need to put another stent or do any kind of intervention to the circumflex. And that is our aim in most of the left main bifurcation or such kind of bifurcation situations where single stent should do the job. There is no need to put the second stent, and we get a good result here. So that is about, like using FFR in osteal lesions, and also you saw, in a bifurcation situation like this, if there is no need to do any further intervention, you can just, simplify the procedure and go ahead with that. Now look at this multivessel disease. I think this is something, very, very common in our day-to-day practice. And here you see that multiple lesions in the circumflex and multiple, it's like the plaque-laden artery, LAD. Where do you put a stent? Which one is the culprit? Nobody knows. But then when we check the RCA, and here you see that these are multiple lesions going into the OM, and we do the RCA. Of course, RCA showed that there is a significant lesion in the proximal RCA. I'll just show it to you. In the mid RCA, sorry, that was the culprit. So we treat that, but in the same setting, we have to make a decision whether we do anything for the LAD or circumflex. So look at the LAD. The entire LAD is 0.86 only, which is very good. So there is no need to do anything to the LAD. We can put it on medical therapy. The circumflex is also tested at the same time, 0.84, so nothing has to be done. And the patient just gets intervention to the RCA, which is fairly simple. So the job is simplified. However, many times people think that when you do FFR, you spend more time, but here you see that you spend less time, and then your decision is made quickly. So this is about in multivessel disease, long lesions, diffuse disease. It is very, very important to do these physiological testings. Now there's another patient here. Look at this. This is a LAD diagonal bifurcation, and of course RCA is tight here in the proximal. So what do you do with this bifurcation? Of course, any bifurcation has to be only treated when it is really important to treat that. So, and we have to take this decision. So in this, we decide that we treat the RCA, and once the RCA is treated, then we go ahead and do the, the FFR to this LAD, which was, you can see here, this is the LAD, which is not looking so much in this view. And then in the other view, it was looking like about 60-70%, maybe going up to 70%. And then the decision had to be taken, but the FFR is good. We do nothing. And in this view, in the iliocranial, you see that the LAD is taking a big bend. And that is why probably it was looking like a lesion which is borderline. And in the ilio also it looks borderline. But the FFR to both LCX and LAD is normal, so we leave the patient like that. So these are so many, day-to-day examples where we can really substantiate that we can simplify the procedures. Now this is an Instantary Stenosis. Now look at this. This is an Instantary Stenosis where the LAD, proximal LAD lesion where the stent has been placed doesn't look very tight. And this is only a few months back where the intervention was done. But the distal to the stent, we find that there is a disease in the segment beyond the stented area, which was tight. So we say, okay, let us put the wire, and the proximal segment doesn't look so tight. So we said, okay, we'll put dilate this distal segment beyond the stent, put a stent distally, and then we will assess it with FFR. So we did the FFR in the proximal segment and found that it is still 0.78, which means that the in-stent area is not healthy. So then what we do is we do a imaging, and then we do a, you look at this imaging, and in the proximal segment, you can see that it is a angiocore registration. You can see that this marker is going up. This is the distal stent, which has just been implanted, which will overlap with the first stent which was done earlier, which was not looking so tight. And proximally, you will see that in the first stent there is a disease which was not so prominently coming up in the angiogram. You'll see here. Now you see the first stent which was done earlier, and at this point it is becoming very narrow at just one point. You can see that the disease is quite significant, and that is why the FFR was positive, and that it was important to treat that area. So we started dilating this proximal segment, did a drug-eluting balloon at the site, and now you see that this is a hybrid of DEB and DES in this very important LAD. And finally, of course, we did the OCT to see the final results, which was quite interesting, and the patient did very well after that. So that was about the diffuse disease, and then Instantary Stenosis. Now looking at the bifurcation. Now this is something which I do many times, and here you see that this is a lesion. Especially I do in bifurcation lesions, and this is the osteal LAD lesion with a long LAD segment, which is disease, which needs treatment, but the circumflex is borderline. Now what you do, and here it is very clear that the stent has to be put from the left main in going into the, almost from the left main going into the circumflex, going into the LAD. So what we do here is, and this circumflex is borderline. So what we do here is we put a wire, now especially with this, because the same wire can do RFR and FFR. So what we do is, once we have taken all the shots and in different angulations, you can see that the circumflex ostium is about 50-ish, 40-ish or something like that, but certainly not significant. And we would much rather like to leave it alone if as much as possible. And this is the RCA, which is normal. So we RFR in the LCX wire, the same wire, the pressure wire, and continuous RFR monitoring is being done to this vessel. So this is the wire which is doing the continuous monitoring, and then we are doing the intervention to the LAD without any hesitation. We are not scared. We have the wire, we have the monitoring, we do this pre-dilatation, and we keep checking. I mean, it is continuously visible that the RFR is doing fine after the pre-dilatation and after putting the stent, and then of course post-dilatation, which is being done. And in here you see that this is the final result, and this is the final result. The circumflex ostium is almost the same, and the flow is good, and the RFR is fine, which means that now it's time to just leave it alone. There is no need to do any intervention, and you avoid a very unnecessary stenting in this situation, and also avoid subsequent unnecessary restenosis to the circumflex ostium, which is, I always call it the Achilles heel of bifurcation lesions of the left main. Now the last case, I'm going to show you lesions like this. What do you do in this? And in here, how many stents? And this is a elderly patient. The creatinine is 2. So what do? You don't have to do OCT in all these cases, because the patient cannot take it. Neither you cannot put any multiple stents. So in this we do FFR, and when you do FFR to the LAD, to the diagonal 1, to the diagonal 2, and the RCA, what do? What we find? So in all these suspected lesions, we do FFR. We find that in the LAD, diagonal, and the D1 and D2, all the FFRs are negative. So this old man doesn't need stents here, and we only need to do the RCA, which was significant, and the procedure is done with just 20-30 ml contrast, and no injury to the kidneys. So basically, this simplifies the procedure in these kind of complex situations. And as you can see here, that when there are multiple stenosis, when there is multivessel disease, when there is acute coronary syndrome, diffuse disease, and there is no focal stenosis for that matter, in these patients we can use FFR and certainly make the procedure simpler, safer, and easier. So with this, I think I'll stop here. Thank you very much.
Thank you, Praveen, for your excellent talk covering vast areas of different subsets of patients where FFR could be utilized during PCI. Now, one or two comments or suggestions on what you have said. One is the role of FFR in selecting non-conflict lesion for PCI in STEMI. That's the first part of your talk. It is useful. It has been found that non-conflict lesion could be interrogated during the primary PCI itself, and the value of FFR obtained remains almost the same even after 45 days, and you repeat the FFR in the same vessel. So that has supported the use of FFR in the acute stage itself. And however, the dynamic 3 primality and the compare acute which has used the FFR in revascularizing STEMI patients for a complete revascularization. It has resulted in reduction of death MI and repeat revascularization, but it was largely because of reduction in repeat revascularization, not on the hard endpoints. Subsequent to that, the largest trial, that is the complete trial, which is encompassing more than 4,000 patients of STEMI, which has shown that angio-guided has resulted in reduction in MI, apart from reduction in repeat revascularization, putting more effort to be done to bring back the FFR into clear acceptance. And I think that is where we are working on right now. The FFR-based complete revascularization, what you call as immediate revascularization versus stage randomization of that group will answer the use of FFR. But still, the second area of confusion was, if you go by 0.80, are we going to miss important lesions? Because of the microvascular dysfunction, the FFR done in that particular non-corporal lesion, which is sharing some degree of microvascular dysfunction, the FFR may remain higher. And if it is instead of 0.82, 0.82 or 0.84, you may defer. And it has been shown that vessel-oriented outcome in the future is higher while you defer with FFR. So certain questions are still to be settled in terms of use of FFR and ACS, but I think it is a good way to go by so that you will be more rationalized. Yeah. And second, of course, is multivessel disease. One of the most important things of systematic use of FFR in multivessel disease is resulting in reclassification of the lesions. Roughly about 40% of multivessel disease could be reclassified. So many cases may not require bypass. As you have shown nicely in the last case itself, the left system disease was insignificant and resulted in RCA lesion only. So that's very important aspect of multivessel disease, use of functional assessment. So that and it has also been shown that functional based revascularization in multivessel disease resulted in a composite endpoint of death, MI, and revascularization. Mostly there, the reduction was because of the myocardial infarction. So that is one important thing. Coming to bifurcation, what I find is that in my practice, after stenting, the side branch pinching could be interrogated effectively, especially left main in case of circumflex pinching. And if you find that it is a significant, you go for a procedure with another stent. If it is insignificant, the most important advantage is that you can avoid a complex procedure in that scenario. But upfront, pre-procedure, well, in bifurcation, you have shown one case nicely that the main vessel has got a lesion, whether it is significant or not. There, one question towards you is that, should we interrogate the FFR of that main vessel lesion, both from the branches? If you pull back from one branch, sometimes the lesion in the main vessel may be oriented towards the other branch. So should we do both the branch before you say that it is the lesion is significant? Please.
Okay, so very nice comments and very, very appropriate. I must say you really brought out the gist of the whole idea of this presentation. Thank you, Dr. Bahulian. And for these two questions, which I see here, that elaboration on FFR and culprit vessel. Basically, in a culprit vessel, so in an acute MI or an NCMI, I don't think there is any need to do the culprit vessel FFR, but certainly the non-culprit vessel FFR is recommended. And I generally recommend that you first do the culprit vessel and then do the FFR on the non-culprit vessel, and then make your decision whether you want to treat it or not. And again, I reiterate here that this is something which I found very interesting, that for India, for our patients, it is very good that you do the whole thing very scientifically at the same time without increasing the cost. And also, I must say, or do not say at this time, that we are able to sometimes reuse the wires, so even that brings down the cost. And then, of course, the second thing somebody has asked, can we jail an FFR wire? And I have seen many times this question being asked. Let me tell everybody that FFR wire can be jailed without much issues unless until it is not beneath a stent. Because in case there is a stent somewhere and then you are putting a second stent there and then the wire is jailed, then I don't think it's a good idea for any wire. But otherwise you can jail it. And especially if the vessel is very heavily calcified at the ostium of the circumflex or at the ostium of the branch, then be careful, because it may be a little difficult to pull out the wire from the jailed situation.
Well,
Praveen,
Dr. Hiramat?
yeah, Praveen, excellent talk again. The issue is when you have multivessel disease and you decide that out of 5 lesions, you would address only 4 and leave behind 1. I mean, do you do sort of re-evaluation at the end of the procedure again and sort of establish a post-PCI syntax score, which sometimes people believe in long term this would be useful? And corollary to this is that suppose you decide not to address a particular lesion because the FFR is sort of borderline 0.84, 83. How do you follow them? I mean, you call them pretty frequently, or because the lesion is borderline and LAD could be a critical lesion, proximal LAD. So what would be your take on follow-up on this?
Very good points raised by Dr. Hiramat. Very wise ones, I must say. It shows your seniority and your maturity. That in those patients where we leave a 0.83 or a 0.84 FFR lesion, and then what do we do? I mean, initially I was also a little bit skeptical and scared that maybe this patient will come back in 6 months or 8 months or 9 months. Let me tell you now, I started doing FFR about 10 years back. This was in 2010, and many patients who were with 0.83 and 0.84, initially the apprehension was there, but now I don't feel kind of scared at all. Basically, these patients have to be followed up in the same way, and of course, now we have better therapies. We have now SGLT2 inhibitors. We have diabetic treatment, which is much better, and we have statins. We have PCSK9. So we do all those kind of things in these patients and just take care of them much more intensively than others. Otherwise, there is no need to do any further angiography or any evaluation of that particular lesion in any special way.
Thank you.
Thanks.
Regarding multivessel disease, we have now data showing that when you refer patients for CABG, assessment of FFR in guiding the surgeon, that is becoming an important area. For example, if there is a borderline lesion and the surgeon is asked to graft, probably he can give a venous graft because arterial grafts on borderline lesions are found to have poor outcomes. So if we, so probably in future, if when we have QFR coming up, I think all our patients will have a QFR assessment before going for a bypass surgery.
Absolutely.
Second is post dilatation of, I think if we, because we have the RFR now, which can be continuously measured without any additional thing. So we can see the effect of after the stenting and reasonable post dilatation. We can see the RFR value, and if it is not reasonably good, for example, it is more than less than 0.9 or something, we can go ahead and post dilate the lesion to make it the result much more better. So these two options are there.
Absolutely. Yeah. So Dr. Harikrishnan, I think these are the two very important points about the surgery thing. The idea is excellent. We do that many times, but unfortunately, there were 2 trials which were done in this arena on guiding surgery by FFR, and one of the trials which was found to be negative actually. So where FFR did not lead to any benefits in patients who underwent surgery through FFR guidance. And these were, I think, 2 years back, we had these 2 trials which were done. But certainly, as a logical thinking, it is absolutely and is reasonable to do this. The only issue is that in surgery, we are actually kind of bypassing all the lesions at the same time. So maybe that is the reason these trials were not 100% showing the benefits. But otherwise, I think it is quite reasonable to do that.
Yeah, this is very true. I think that's why surgeons are probably not looking at the FFR. Probably FAME 3 trial will bring in a different angle of data. That is FFR-based revascularization versus CABG. So that will give a different answer, not from the point of view of surgical point of view. Any questions, Sergeant? Any comments or any?
Yeah, just a comment on utility of FFR when evaluating a culprit lesion, STEMI. For example, we encounter a lot of patients who present late, and we don't know what is the viability in that territory. For example, a person has an evolved escalation MI, In anti-roll isolation MI, comes probably 5 days, 6 days later, and you find an 80% lesion and echo shows an extensive wall motion abnormality. What is the validity of FFR? Still, FFR is relevant in that situation because we know that FFR is directly proportional to the amount of viable myocardium. And studies have shown that the microvasculature regains the reactivity to vasodilatory stimulus probably about 5 to 6 days after the event. So it is also useful in guiding intervention in patients who are late presenters, in evaluating a culprit lesion in ST lesion. So that's also valid in our scenario because we've got a lot of patients who present late, especially in COVID times.
Yeah. Not in the immediate phase, probably after, say, a week.
5 days, yes, 5 days. And a failed trial has included patients about 7 days after the index event to evaluate a culprit lesion.
Yeah, in that situation, there are two things. There can be some amount of stunning which can have a problem. And second is the LVED will be elevated because of the stunning and the LV dysfunction, which can affect the FFR. So these two things we have to keep in mind when you consider the point raised by Sajan.
Yes.
I think we can have the comments of Dr. Niels here, who is already there. And maybe, what is your comment, Dr. Neil, on these 2 points on recent MI with a almost infarcted vessel? And the second is on the bypass decision on patients who have multivessel disease undergoing bypass surgery.
Yes, thank you, Dr. Chandra. It's a pleasure to hear so much insightful comment about FFR from you and from everyone on the panel. I think that the issue after infarcts is how big it was and how recent it was. And the larger the infarct and the more recent it was, the more that you're going to run into the issues that many of you have raised about microvascular dysfunction and high LV filling pressures. I don't know of a hard rule, but I agree with many of your comments that largely once you're several days or at least a week away from a not so large infarction, that FFR is a very valid tool. The extremely large infarcts that happen are usually ones that we don't have so much of an issue on about using FFR. Often it's obvious angiographically what to do with those ones. So generally most of the cases where it's a question of what the culprit is, that those tend to be the infarcts that weren't very large anyway, and that some time has passed. As for bypass surgery, it's interesting, the design of those trials, I think, is really behind the reason that they saw the results that they did. And that's that when you have a bypass strategy where you just bypass everything, and then you have a, say, tailored bypass strategy by FFR, that the only reason that the trials differ is on the vessels that were FFR negative but got bypassed. And the way those trials were designed, it's not easy to tease out that subset from the much larger group of lesions that were FFR positive anyway and would have got bypassed regardless if you'd used FFR or if you had not used FFR. And so one of the things that the investigators in Graffiti and then the other trial, whose acronym I forget, is they're actually going to do a vessel level analysis, pooling both of those trials together, because really it's a vessel level diagnostic technique. And so the outcomes need to be at a vessel level. Does the graft fail over time versus does the non-grafted vessel then need percutaneous revascularization over time? So that's something that I think will come out through the course of the next year or so and give us more insight.
One last question, which somebody has asked, is very, very interesting. I think is very relevant, that once we thrombolize a patient and then we bring him to the cath lab, whether he is successful or not successful, that's another question. But if we find a borderline lesion on angiogram after maybe a successful thrombolysis, then what to do? I think this is interesting. We have to combine these two things together, the information which comes from the angiographic studies and comes from the FFR studies, that you have to wait in these patients, because in like from the frame trial also, they were again, we can check it them after 7 days, or we can even bring these patients back into the cath lab at 6 weeks. Maybe either do a non-invasive evaluation of these patients, doing a nuclear scan or a stress testing, or you can bring to the cath lab and do FFR to these patients. So I think these 2-3 possibilities, according to me, seem quite feasible, but I'm sure my other colleagues will have some other suggestions on this.
I think if it is intermediate lesion after a week's time, it could still be assessed whether it is significant from the point of view of FFR. That is possible. But I think in this scenario of using widespread use of imaging, it will definitely an additional point to do an imaging in that situation about that lesion. The plaque rupture still continues to be there and minimal luminal area reduction. So if you add on the high risk plaque characteristics to the FFR, that may be more meaningful to select such lesions to be taken for PCR.
Yes,
Julian, I would feel that in these cases, there has been obviously a successful thrombolysis. The underlying lesion is not very critical. So in these cases, I would expect a reasonably preserved LV function and also reasonable microcirculation patency. So on both these factors, microcirculation as well as LV-EDP, which are likely to affect the FFR, they are not going to be there in this particular case. So I think it would still be reliable doing it during an acute phase. You should do it because it sort of helps you decide whether you are going to conserve this patient at a later date. And I would probably do a stress thallium after a few days just to make sure that it does not need anything more.
The upcoming TCT meeting, we are expecting a trial called Prospect 2, which is expected to be presented, which will look into what is the value of intravascular imaging in such situation, exact situation which we are discussing, and what is the long-term outcome of a preventive stenting, exclusively based on imaging characteristics. So within a couple of weeks, we will know what is the result of Prospect 2.
In fact, one of the studies which is being planned and being partly being done is the OFR study, where you do a OCT, and then the OCT will give you anatomical results, and also at the same time, it will measure the FFR through a fluid dynamic formula without using the pressure wire, which is now being called as the OFR. So these new technologies will really help us take right decisions in these difficult patients.
Acute coronary syndrome is a different situation altogether. It cannot be assessed only by the functional assessment because the plaque morphology has a lot of things to be done. So understanding plaque morphology and adding it on to what you get by the FFR may be a helpful denominator to decide on the revascularization. I think we had a very nice discussion, nice presentation. Excellent, Praveen. Thank you very much. I heard you are busy with some other.
Yeah. Unfortunately, I have to leave. And so thank you very much and all the best for the next part of the session.
Thank you. Deepak, shall we move on to the next talk?
Yes, sir. Yes, sir.
Yeah. So now I have the great pleasure to invite Dr. Niels, who is an international expert, and you might have read his articles, listened to his webinars on the functional assessment, especially FFR. So today he is going to cover the tips and tricks of FFR. It is of paramount importance to get a good that is the importance of knowing the tips and tricks of doing a good FFR testing. Dr. Niels Johnson, please.
All right, thank you so much. I just want to make sure that the slides look all right and that the audio is good. Okay. Yeah. All right, we're on track then. Hello, everybody. Thank you. Good morning from Texas here. Sunday morning for me, of course, Sunday evening for all of you. Thank you for the invitation to attend this session and to talk about FFR in a very practical way. And so the way that I've organized this is through a series of case presentations that highlight different tips and tricks. And then in between the case sessions, I have several slides looking at various troubleshooting things with FFR and how to address those. So hopefully it'll be a very practical session. You can think about how you would have treated these cases. These are my disclosures and nothing's related to this particular talk. So the first clinical case is a 58-year-old man who presented with an end-STEMI. You can see his EKG here, and he had fairly typical symptoms when he arrived. His echo showed relatively normal wall motion, but some dynamic enzymes, stuttering, chest pain, that had been building over several months, but then had become quite acute. And so this is the initial angiogram that I took, and I will then show you my initial thoughts on the angiogram. And looking at the RCA, I thought, well, that looks like the worst lesion to me. That's probably the culprit for what's happening. So maybe we could just stent that vessel, for example. But then you take a picture of the left side and see a very eccentric lesion in the osteocircumplex, and the LAD has some lumps and bumps to it, nothing that's too eye-catching in the various views. And in this case, maybe you wouldn't even think to use FFR, but as Dr. Chandra and several of you have brought up, I think it's a valuable tool for understanding, probably not the culprit lesion, but certainly understanding what the non-culprit disease is. And in this particular case, the FFR of the RCA was 0.63 with a very focal jump on it. So I felt that that supported the case that that was probably the culprit for this. I wasn't too surprised that that osteocircumplex had an FFR of 9.7, but then perhaps the surprising message or the take home from this case is the FFR of 0.64 in the proximal portion of the LAD that also had a very focal pressure jump over top of it. And because this patient was young, he was diabetic, and also had good distal targets, I sent him for bypass surgery, but I could certainly understand if, depending on your local practice pattern, this had been someone that you would have stented the LAD and the RCA. I think that's not so much the important point of the case. The important point is that unless you understand the disease in the LAD and you only treat the RCA, you're going to be undertreating this patient and perhaps then be puzzled why he would come back with symptoms down the road or have a suboptimal clinical outcome. And this kind of disease that's angiographically not so dramatic, but yet very physiologically important, is something that's seen in every series. I've shown you an example here, but let me show you data on the left-hand side from a large series in Belgium, and on the right-hand side from a study called Ripcord in the United Kingdom. And looking at the less dramatic percent stenoses, less than 50%, you can see that there are lesions that have a very dramatically low FFR values. And this just, I think, is a redemonstration of a concept that is familiar to many of us, and that's that there can be a very large disconnect between the severity that we see on the angiogram and the functional importance. Usually we think of it the other way around. We're very drawn to focal lesions on the angiogram and are surprised when they're functionally not significant. And this is the opposite, the flip side, if you will, that lesions that maybe aren't so dramatic on the angiogram have low FFR values. These are two other cases from my practice. Several years ago when I was in the Netherlands, you can see patients either with anginal symptoms or with arrhythmia problems who have very low values in the LAD, despite just having what we might call luminal irregularities or lumps and bumps in the LAD itself. And this is the kind of disease that is, I called this case hiding in plain sight, that's just hiding right in front of us. This was some work from Stanford where they took a group of patients who were felt to have microvascular angina and performed routine evaluations. And what they discovered is that in that group, 5% of them had low FFR values, meaning that patients will receive this label of non-obstructive coronary disease, and even despite a lot of testing upstream, can still find low FFR values, just emphasizing that this disease can be hiding right in front of us. So that was the first clinical vignette. I want to go on to what are a series of very brief hemodynamic tracings in order to think about troubleshooting FFR so that we get really high quality data. All of them have a very similar appearance. This is what it will look like. This is a tracing using the older RADI system. The coronary pressure is in green, that's the distal PD. The aortic pressure is in red here. You can see in this particular tracing, the first two beats are on one time scale and the remaining beats are on a faster time scale. And I've given several choices here over to the side. You don't need to vote, but just maybe in your own mind, think about what's causing what we see on the screen and what you would do to make it better if you had to troubleshoot this in the cath lab in real time. And this is an example of WIP. You'll notice here during the very peak part of systole that the pressure in the coronary artery, the green pressure, rises dramatically above the red aortic pressure. You can see here that the aortic pressures may be at 140 millimeters of mercury, but the pressure in the coronary wire spikes up to over 200, almost 250 millimeters of mercury. And this happens with every single heartbeat right at the peak of systole. And the reason that this happens is that the pressure sensor is being thrown against the wall of the blood vessel with the systolic motion of the heart. And because that pressure sensor then slams into the wall of the blood vessel, it does receive a pressure spike up to 200. That's not the pressure in the coronary artery. That's an artifact of the pressure sensors being in a poor spot of the vessel and being whipped, as we call it, against the wall of the blood vessel. And so the solution is to take the slack out of the wire, either by pulling it out or by moving the pressure sensor forward in order to move it to a different part of the vessel where this won't happen. The clues that would have allowed us to troubleshoot this on the pressure tracings is that normally a minimal stenosis is going to preserve the dicrotic notch on the pressure tracing in the coronary artery, and there should be a gentle fall of the pressures during diastole. And as the lesion becomes more moderate, the coronary pressure tracing loses the dicrotic notch. There's a larger gradient in diastole because that's when there's more flow. The aortic pressure does not change, it stays the same. And then when we get to very severe lesions like this one with an FFR of 6.9, again, the aortic pressure is the same. There's still a crisp dicrotic notch, a very gentle fall during diastole, but we have a coronary tracing that's almost what you might call ventricularized, no dicrotic notch, and a very low flat pressure during diastole. So we'll jump back to a clinical case. This was a 65-year-old man who came in with chest pain. It was a stable coronary syndrome. His cardiac enzymes were negative. He had the usual assortment of risk factors and was being treated for those. He had coronary calcium by CT imaging, and he had a SPECT at an outside institution that showed a defect in the inferolateral wall. So I do my angiograms by taking the RCA pictures initially. That's just my habit. And when I took the RCA angiogram, I saw what I thought was a moderate to severe proximal lesion in the RCA with some mild to moderate distal disease. And given that the SPECT showed a defect in the inferolateral region, I, in my own mind, made a treatment plan. I said, hey, this is something that we need to do PCI on. However, then when you take the angiogram of the left system, it became more complex. There's just some mild disease in the proximal LAD, but of course, there's some moderate, and depending on what view you have, maybe even moderate to severe angiographic disease in an OM branch that also supplies the inferior lateral wall. And so this then is the clinical question. We have a SPECT defect that could be interpreted in two different ways. Is it the RCA by itself? Is it the OM branch by itself, or is it both of them together? And of course, this is a patient who has atypical symptoms and also is obese, has a body mass index of 36. And so someone in whom you might easily imagine that the SPECT images might be suboptimal or complicated by attenuation. This is really a classic FAME1 patient, someone where an angiographic strategy proved less good than an FFR guided strategy. And so I said, well, let's get the Ffr wire out. I equalized it here in the right coronary artery, and then I placed it down in the mid-distal portion of the posterior descending branch. And you can see that the baseline gradient was 0.90. And then I turned on adenosine. I usually use IV adenosine. And this is the next 2 minutes or so after turning it on. You can see that the resting PDPA was 9.0 and fell down to an FFR of 0.76. So is this the kind of vessel that we should be doing PCI on? And the teaching point for me from this case was that you still need to understand if the lesion that you are measuring is the culprit and if you had any significant drift. And here's the pullback part of the tracing. So although the distal FFR is 7.6, when I pulled back the wire, you can see a large jump over that proximal lesion. But yet in the aorta, we only get back to an FFR of 0.89. In other words, at the beginning of the case, when we equalized, the two pressures were the same. But at the end of the case, when the wire was brought back to the aorta, it was only 8.9. And this is due to drift. It's one of the most dramatic examples of drift I have in my collection, but I show it for that reason, that if you don't look for it, you won't understand that the measurement that was made was actually biased. And the reason, one of the clues I think that you can already see that is that, as I was talking about, when you develop a pressure gradient, the morphology of the coronary waveform should change. So on the left-hand side, we have drift, where the pressure wire has the same waveform as the aortic pressure tracing, crisp dicrotic notch, gentle fall during diastole, but a large gradient And that's not the way that coronaries work. On the right-hand side, it shows you that when you develop a pressure gradient that large, you have to have a change in the waveform morphology. And that was one of the clues here as well. This is some data that we collected excuse me, several years ago as part of the contrast study using the older generation Ffr wire. You can see 1, so very good performance, about 80% within 0.03 and over 90% within 0.05. But you can see some real outliers. For example, my case, it wasn't part of the study, but something like 0.89 does have a lower FFR due to the larger amount of distal mass, even though the angiographic disease is less dramatic, an FFR of 8.4 and no drift on pullback. So really someone whom, if you looked at it, you might have said, well, this is angiographic two-vessel disease, the OM, as well as the RCA. But when we make FFR measurements, we see that actually this is zero-vessel disease. And as some people have noted earlier, this is something that the FAME trial showed as well. About 10% of patients who were thought to have two-vessel disease based on angiographic criteria actually had zero-vessel disease based on FFR. So again, I want to switch over and show you a hemodynamic tracing. Same presentation. Red is the aortic pressure. Green is the coronary pressure. The vertical yellow line is where the FFR measurement is being made. Often the computer or hemodynamic console will mark that piece. And what is the issue with this? And I give you the same 4 choices that I showed you before. And this is a problem of the computers doing the wrong pick. You'll notice here that the operator has probably made this measurement using intracoronary adenosine. The aortic stopcock was open for 4 or 5 beats while that injection was made. And it was during that time then that the lowest PDPA value was found. And so the computer is not very smart. It just says, hey, let me put the cursor wherever the lowest value is. But in this case, it was during a segment of the tracing without valid data. And so this is a reminder that every time the computer makes a measurement, it's up to us to make sure that it's made a good choice, a smart choice. And this is something that is also helped by actually being able to store and review the tracings. It's often very easy for us to store and review the angiographic tracings. There are many good PAC systems for this. Sometimes our hemodynamic software doesn't make it as easy to store and review the pressure tracings as well, so that when we discuss these cases with colleagues or in the heart team, that we're able to go back to the raw data, just as we would with the angiogram, and make sure that the raw data supports the clinical decisions that we're making. All right, next case is called contrasting views. This is a 70-year-old man who came in with an acute coronary syndrome. Very sudden onset of substernal chest pressure while he was at home, came immediately to the emergency department, and this was his presenting EKG. I took him to the cath lab, and these are his angiographic images. And again, I will show you my immediate reactions to them. When I shot the left system, I looked at the LAD and said, yes, that is the culprit in my opinion. It matches with the EKG, a really hazy subtotal lesion. But of course, there's a disease in the circumflex. It looked to me to not match up with the EKG for being the culprit, but angiographically, it looked moderate to severe, and then mild disease in the right coronary artery. And as several have brought up, that you don't need to use FFR for clear culprit lesions, not for the culprit in STEMI, not for the culprit in NSTEMI when it's so clear. So I straightforwardly, without using FFR, went ahead and did PCI of the LAD. And then it's a question of what do you do with the non-culprit disease? And as I think has been commented before, there is the potential to really reduce repeat procedures for patients if you can do it all as part of the same index case. That reduces costs for the healthcare system and for the patient, and also can immediately then have the diagnosis be made. And so because the LAD PCI was so straightforward, I put a pressure wire over into the circumflex. And I don't know what you do with your FFR wires, but once I've got in place, I give a little bit of contrast so that I can document where the wire position was and make sure that it's well positioned. And here, when I gave contrast, the value went down to 0.63. And so I went ahead and then did PCI of the circumflex. And this is a notion that's called contrast FFR, that is making an FFR measurement, not using a medication like adenosine for hyperemia, but instead using contrast. The advantages, of course, is that contrast is always there. It's set up for angiogram, so it doesn't require any extra effort. It's readily available. And interestingly enough, it does produce some degree of hyperemia. And this is a slide that emphasizes some of the mechanisms for why it causes hyperemia. On the very leftmost is a study that we did several years ago, looking at blood flow in vessels when we injected venous blood, when we injected saline, and when we injected contrast. And you can see that all three of those injections cause an increase in coronary flow. And the middle slide then is a study of making saline FFR measurements. That is where you just do a saline injection for several heartbeats and then look at the values. And because saline causes a rise in flow and a drop in the PDPA values, a large part of why contrast causes hyperemia is simply a reactive effect of replacing oxygenated blood with deoxygenated blood for several heart cycles. And because of that, the heart muscle then has reactive hyperemia. The most extreme example of reactive hyperemia, of course, is if you do a balloon occlusion and then take the balloon down, there you have a big surge in flow because of that transient period of hypoxia. But even injections of venous blood, saline, contrast, you probably also see it sometimes when you give intracoronary injections of nitroglycerin or other vasodilator medications and you have a pressure wire down, you'll see that the gradients go up. The reason for all of those is reactive hyperemia. The reason that contrast gives an additional hyperemia over saline and venous blood then has to do with other properties, the change in viscosity and potentially also some of the effects of the iodine moieties in contrast itself. This has been the topic of a trial that we did many years ago now called Contrast, where we took measurements in coronary arteries using PDPA and IFR twice. We then did contrast injections twice. We did IC adenosine twice, IV adenosine twice, and then did a drift check at the end. So really trying to understand the repeatability and comparability among these different metrics. And as you can see from this particular case, contrast FFR is a very fast medication. It's a very sharp drop to hyperemia with a very fast return to baseline. Compared that to the wider curves of intracoronary adenosine, and of course IV adenosine lasts as long as you have the infusion running, and quite repeatable, as in this case. All of these measurements tend to be the same over a short period of time if you make multiple measurements. But it's an interesting case where the resting physiology, the PDPA and the IFR, were both negative. But even with contrast, you can see that this lesion drops down to about 0.76. And of course, the FFR with adenosine was 0.7. So contrast then, in some ways, is maybe like 5 mics of adenosine or something like that. It gives you some hyperemia, not full hyperemia, but it's interesting how often it's enough to improve your diagnosis. And this is a comparative study then looking in 3 different series, ours, as well as a large multi-center registry called Memento, at the diagnostic accuracy of contrast FFR compared to PDPA here in black. And in each one, contrast FFR increases the diagnostic accuracy from somewhere around 80% by using resting physiology to almost 85–90% by using contrast hyperemia. And on the right-hand side, that's also displayed in the larger area under the curve. So clinical follow-up for this patient, as you recall, I did PCI of the LAD without FFR because that was the culprit, and then used contrast FFR guided PCI the circumflex. He did well. You can see the normalization of his EKG afterwards. These were all hyperacute T waves from his infarct with the relatively normal echo in follow-up and enzymes and other data as advertised. So to summarize then, a practical algorithm is if you put the pressure wire down and the ratio is already 0.8 then or lower, then PCI is reasonable. Of course, you lose information about the depth of ischemia, something that we've learned is important. And because the pressure jumps are smaller, the pullbacks are less sensitive. But if you just want a yes or no answer, it's certainly very reasonable. If it's above 0.8, if you give contrast, you'll find another 20% or so of lesions where the contrast FFR is 0.8 or less, meaning that the FFR is going to be at least that low, if not lower. This maintains 100% accuracy, but does streamline your evaluation. And then for all of the other patients, adenosine will pick up another 20% where it's most reasonable to perform PCI, and the rest could be medically treated. So another quick quiz. This is another waveform. Red is the aortic pressure tracing. Green is the coronary tracing. You can see where the marker has been placed with the vertical yellow line for the FFR value. And again, I give you the same 4 choices. This is something then that I'll show you over here on the results what it is. So this is damping, and what you'll notice in contrast to the other cases is that the aortic pressure tracing, it does not have a crisp dicrotic notch and a gentle fall during diastole. This aortic pressure tracing looks like a sawtooth. Additionally, the peak-to-peak amplitude of the aortic pressure tracing is lower than the peak-to-peak amplitude of the coronary. While the average pressure in the aorta is higher, the peak-to-peak, the pulse pressure is lower. And what's happened here is that the guide catheter has become filled with something, either bubbles or contrast or sometimes atherosclerotic debris. And as a result of that, the waveform has become damped with this very sinusoidal sawtooth appearance. The solution here is to vigorously flush the guide catheter and remove this. It's interesting, we looked in contrast study at a large number of predictors for this distortion of the aortic waveform, and in some cases injecting things into the coronary artery like contrast or adenosine can increase the risk. So you should always have your eye on the pressure tracings when making these measurements, especially when you're doing intracoronary injections of things, to make sure that you haven't caused a damping of the guide catheter. All right, twins are different. So this is a case of 2 studies. So I'm going to jump back one. So 2 patients, you can see the clinical histories here at the bottom. And they're both LADs, and they both have FFR values that are quite severe. You can see both of them are less than 0.7. And so you might think at the beginning that these are very similar types of vessels, both LADs, both symptomatic or clinically important, and both with low FFR values. But during a pullback measurement, you see that these twins or apparent twins on the surface actually have very different physiologic patterns. On the left-hand side in this LAD, you see as I move the pressure wire back from the distal vessel to the aorta, that there's just a very gradual decrease of the pressure gradient shown down here at the bottom. There's not any one spot where the pressure gradient jumps. It's a good measurement. We get back to almost 1 at the beginning, so there's no important drift. Whereas the case at the right-hand side, while moving the pressure wire back through the vessel, right here at this proximal lesion, boom, there's a sudden jump up almost back to 1. And this then highlights the important information that we get from doing pullback curves, and that's the pattern of coronary atherosclerosis. Is it focal, as on the left-hand side, where even small movements of the coronary sensor cause large changes in the gradient? You can pull back and push across the lesion and have a very large jump in the gradient. Or is it diffuse disease, where there's a gradual coming together of those 2 curves? As you might expect, focal disease is really our best target for revascularization in general, and diffuse disease, while clinically important, unfortunately does not respond as well to our revascularization techniques. Diffuse disease is very common. This is a study from almost 20 years ago now, just highlighting how many patients who have arteries that look like the one here, these kind of lumpy, bumpy, diffuse diseased LADs, have FFRs that are low. Almost 10% of them had an FFR less than 0.75, and almost all of them had an FFR less than 9.2, which is fairly typical in an LAD. So diffuse disease is widely prevalent, and it's important because it impacts prognosis. When we perform PCI of a vessel, we largely remove the focal disease if we do it well, if we target the right areas. So the FFR after PCI is largely a reflection of how much diffuse disease remains in the vessel. And as you can see on the right-hand side, the more diffuse disease you have, the worse the prognosis is over many years. And that's something that's been repeated in many different data sets. Diffuse disease is frustrating for us to treat in the cath lab, of course. We end up putting in long stents or ultra long stents. This was a study looking at the types of FFR gradients that are measured in vessels after implanting long stents, that is more than 50 millimeters, or ultra long stents, which would be, I think in their study, more than 70 millimeters of stent length. You can see that with long stents and ultra long stents, the gradients are at 6 months, which is when they brought them back for a repeat assessment, all the way up to almost 0.1. That is, it would be impossible to have a vessel with a post-PCI FFR of 1.0 once you put in over 50 millimeters of stent and the stents have kind of settled in. You've already lost 0.1 in terms of pressure gradient. You might think that the correct answer then is to treat these patients with bypass surgery. Unfortunately, LEMAs also fare less well in the presence of diffuse disease. This is a nice study from Japan looking at what happens to LEMA grafts when they're implanted on functionally significant disease. That is an FFR less than 0.8, but yet they divided it into focal disease, like here where there's this focal jump, versus diffuse disease. And what they found when they did a CT angiogram several months later is that functional diffuse disease had a failure rate for the LEMA 3 times higher than when it was implanted on functional focal disease. Diffuse disease also means that when we perform PCI, we don't improve the physiology that much. This is an LAD. You can see the pullback here, mainly diffuse. Yes, there's a little bit of a jump right here where the arrow is, and so a stent was implanted, and the FFR went from 7.8 before to 8.3 afterwards, a change of 0.05, a fairly modest improvement. Compared to this circumflex, it has a very focal lesion right here in its mid portion. You can see that as well on the pullback tracing, and a very short stent changed the FFR from 0.59 up to 0.97, an increase of almost 0.4. And it's this change in FFR that predicts what happens to patients, how they do clinically down the road, and also how their symptoms improve. And these are 3 different studies. On the left, data from Korea and Japan showing that the more of an increase you make in your FFR, the lower the event rates. That's also shown here in the middle, data from FAME 1 and 2, the larger the change in outcomes. And then on the right-hand side, looking at functional clinical significance using the Ppg Index, shows that when you have the smallest change in FFR, patients have the least benefit in terms of symptoms. And so one of the things that we can use in the cath lab in order to select the best patients for avascularization are pullback curves. And you can see here 3 LADs, 3 different pullback curves are shown here in blue. Very focal disease, mixture of focal and diffuse disease, and pure diffuse disease. And this is something that's now being quantified. We've often done it with the eye, just look at the pullback curve. But here there's something called the Ppg Index. I've shown the equation, but the point is that when you have a value very close to 1, that's really a representation of focal disease. Values in the middle are mixed disease, and values very close to 0 are diffuse disease. And importantly, as a study was shown at EuroPCR several months ago, it's this Ppg index that very closely tracks with the FFR value after PCI, but perhaps more importantly, the Ppg index shows this curvilinear relationship with the amount of functional gain, the change in FFR from before and after, such that when Ppg indexes are less than 0.6, meaning that there's diffuse disease or mainly diffuse and mixed disease, that you get very modest gains from PCI, whereas the largest gains obviously come from the most focal disease when the Ppg index is the highest. And that's something that is being studied now in ongoing trials. And so this is an editorial that I wrote that came out a month or 2 ago, just highlighting this issue that when we think about FFR, we need to think about 2 dimensions. The first of which is the depth, how low is the FFR value, but also the distribution. Are we talking about focal disease? Are we talking about diffuse disease? And really that the patients who are our best targets for revascularizations are those who have severe FFR values, but also focal stenosis. They respond the best to revascularization. One last quiz here. This is looking at pressure tracings again. Red is the aortic pressure tracing, green the coronary. The vertical yellow line is the FFR measurement, and you can see here the same 4 choices. Of course, now that you've had 4 quizzes, hopefully you've done by process of elimination, which is the only one that's remaining. This is ventricularization. You can see that the aortic pressure tracing here in red has lost the dicrotic notch, and it no longer has a nice gentle downsloping during diastole, but rather has a very flat ventricularized-like appearance. And what's happened is that the guide catheter often gets sucked into the artery, and so you need to pull it back a little bit. And so I have another example that was published that shows much the same thing. Here you can see at baseline, very crisp pressure tracings. During intracoronary adenosine, the guide gets sucked in, you lose the dicrotic notch and have a very ventricularized pressure tracing. And that led to the FFR apparently being 0.90, but the operators realized what was happening. They went back and did the same measurements, but this time after they gave the IC adenosine, just pushed on the pressure wire a little bit, pulled the guide back a millimeter or so, and now the aortic pressure tracing looks vastly different. You can see this dicrotic notch, a nice gentle downslope in diastole. Of course, the coronary pressure tracing is the same, so the numerator doesn't change in the fraction, but the denominator changes, and that means that the FFR was actually 0.73. So this kind of damping, if not paid attention to, can lead to improper choices for making FFR measurements. All right, well, that's all I wanted to present. Several, I think, practical cases from my own practice, and then several troubleshooting steps on how to make good physiologic measurements. Thank you so much. Just a moment, I just want to make sure everyone's unmuted here so we can have a good panel discussion.
Right, we'll have a panel discussion. Very interesting presentation in the sense, you know, we have covered most of the tips and tricks with a lot of case-based examples. So that's a very interesting part. One thing which, before we get into the discussion, I just want to ask one technical thing. This pressure pullback gradient you have mentioned towards the end of your talk. What's the automatic pullback of the FFR? Or?
It's a good question. So initially the work was done using an automatic pullback device. I don't know if you've ever used the Philips Volcano TrackBack. It's a device where you can do IVUS pullbacks. That's how some of those early measurements were made. But actually that's kind of how it was developed. But the subsequent work has all been done using hand pullbacks. And in fact, we've shown that the hand pullbacks versus motorized pullbacks give very comparable results. And so as long as you pull back at a typical speed to do maybe 20 or 30 seconds for a vessel pullback, that's good enough to give a sense of what the PPG is and gives very similar values.
All right, thank you. Now, another question is regarding the hyperemic agents which you are using. You said about that the adenosine you use basically intravenous in your practice, actually. Often asked question is that ICUs, some of the operators are using ICUs. What is your take on? I use personally intravenous in all cases so because of the certain advantages of IV usage. And comparative studies show that the IC gives almost equivalent results, but only thing is that I see different dosages are being used. What is your take on that part?
It's a great practical question, and actually earlier this year we published a large series pooling all of the lesion level data on adenosine IC versus IV adenosine. So it was a huge paper that came out in Circ Interventions, and what we showed is that there are no clinically important differences if you're using reasonable doses, and reasonable doses of IC adenosine are probably 50 to 100 micrograms. Usually larger in the left, and our recommendation is to use larger doses in the left coronary artery versus the right coronary artery. Of course, the disadvantage to using really high doses is AV block, which can be frustrating and sometimes also scary for everyone in the cath lab to have really long periods of AV block. And in some patients who are hemodynamically tenuous, that can also be a little bit dangerous. But as long as you're using reasonable doses, as I mentioned, there's no clinically important differences. If you do huge series, you can sometimes see average differences of 0.01 or 0.02, but those are so small in terms of clinical imprecision, because if you just made a second FFR measurement, you know that it might vary itself by 0.02. And so I think that that's not clinically important, although in some big series you can see it reaching some statistical significance. But to keep it practical, just use 100, 200 mics in the right or left, and you'll get very good measurements. And I must say, I'm an IV user just like you, but there are some patients who have a very reactive airway disease, or maybe some patients who are hemodynamically tenuous with their blood pressures. And I've used intracoronary adenosine in those cases, even though I'm mainly an IV adenosine person like yourself.
Thank you, Niels.
Dr. Niels, one more question about you showed one slide hidden in front of you, and then 5% of these had a positive FFR in some of the vessels. So as I understand, when do you make a search of this nature? Like basically the angiogram comes close to normal, patient has come to you for some symptoms, maybe a positive stress test, angiogram is normal. And then to find out whether he belongs to this 5%, I mean, there should be some clue which tells you go ahead and do an FFR.
It's a question that I think we all struggle with all the time, right? And that's that once you start to realize that even mild disease can in some cases give low FFRs, and like some of the cases I showed, it's easy to get a little bit paranoid about things, right? To start to say, oh my gosh, I need to do every single vessel all the time and everybody, otherwise maybe I'll miss something. And I think maybe what you're alluding to is also where I've ended up at the end of the day. And that's to be we have to be clinicians. We have to put all of the information together. And so I think, as you suggest, to think about patient symptoms, to think about the non-invasive data that's happening, and to really understand, is it a completely normal angiogram, or is this someone that might have a lot of diffuse disease and negative remodeling, like that diabetic patient who had clear atherosclerosis in other vessels and had all of the risk factors? That's someone that I am pushed harder to make measurements in. Whereas a younger person with no risk factors and truly normal arteries, no atherosclerosis, those are the kind of ones that, especially if non-invasive testing is negative, I also don't do anything. But I agree, it's a scenario where it's easy in hindsight to say one way or the other. But when you look at big series or the cases that I've presented, it's always something to keep in the back of your mind that until you've made those FFR measurements, some of those patients might still have big gradients at the cause of their presentation.
So in these who come positive, where would you intervene? I think that is also going to be important. I mean,
absolutely.
Just you get a pressurized.
And I think that, the pullback curve can often help us figure out what kind of disease we're dealing with. Like some of those LADs that I showed that are just completely diffuse disease. It explains the angina, it explains the ventricular tachycardia for those patients. And then it's a practical question of what we're going to do. Is this the kind of person who could tolerate lots of dual antiplatelet therapy? Do we think we could full metal jacket the vessel? Should we just try medical therapy to try to regress it? Should we do bypass? I think that needs to be very individualized based on the clinical scenario.
I mean, most of the time when you have a diffuse disease, especially in LAD, our inclination is more towards surgery, that the surgeon can do a more complete sort of revascularization, sometimes even a jump graft to the LAD with two connections. So you think it helps you decide which way to go, whether to go with angioplasty or whether to go for bypass surgery in case if you come across a diffuse disease, because you showed that even surgery is not the best option for diffuse disease.
Diffuse disease remains a very challenging issue, and I don't have an easy answer for you. What I'll say is that those are the cases that I think I struggle with the most, trying to understand the right, the best treatment option to recommend to patients. And those are the ones that I try to get as much input in the heart team and to take other factors into account.
So can we continue discussion during the live case because they're ready there?
Yes, I don't want to hold up other things. I want to stay on time for other stuff.
Deepak, you're the boss, so go ahead.
They are ready at Maitra Hospital. They are ready with the case. Dr. Ashish and Dr. Jayesh is online. Sir, shall we move over to that?
Yes. Yeah, please. I think so. Yes.
So probably we can continue discussing halfway through the case.
Yeah. Okay. No, let us go to the case. Only thing things that we were discussing on the diffuse disease and where you don't have any step up in the FFR pullback. By and large, that becomes the substrate for acute treatment. That is the prevention is unlikely to help, neither the grafting is unlikely to help. Are you ready, Ashish?
Can you hear us?
Yeah, we can. Hello.
Good evening. Good evening. This is Dr. Ali. Greetings from Moita Hospital. First, thanks for the organizers of this meeting for inviting us and giving us an opportunity to be part of this live session. And especially to Deepak and team there, the senior panelists sitting there, Dr. Barney, Niveman, Hari Krishnan, Bill Johnston, Sajan, everybody. So I hand over the mic to Dr. Ashish and to Dr. Jayesh. Good evening to you all.
We can hear you, Ashish. I think you have to raise your, yeah.
Can you hear me now?
Yeah.
Okay. So we will present the case. The main operator is the primary operator is Dr. Jayesh Bhaskaran, and we have the entire team with us. We with the scholars, Gina.
Ashish, you are not audible.
Am I audible?
Yeah, now
Yes,
better.
can you remove the N95 and then speak? It might be better.
Okay. Is it better now?
Yes, yes.
Okay. So the primary operator I was saying is Dr. Jayesh Bhaskaran, my colleague, and the scrutineers, Ms. Dino, the cat technologist, Ms. Gina and Srirag, and the entire team is here. So I will request Dr. Jayesh to present the case and whatever we have done till now. Case, please.
Can we have slides, please? Good evening, everyone. We have a 54-year-old lady, diabetic, who presented with class 3 angina, normal adequate LV function at 3. Am I audible?
Yes, you are audible. Go ahead.
ECG showed minimal changes. Can we go to the next slide? Next slide. She had mild renal dysfunction and fairly good LV function with inferior wall motion. Next. And she had an angio done a few weeks back, which showed critical proximal RCA lesion, critical Medina 100 bifurcation lesion in the distal RCA, and distal circ bifurcation lesion in the major OM. Can we have the next? So with this lesion, we plan to PCA to mid RCA, proximal to mid RCA, distal RCA, and PCA to LCX to OM. Which for this bifurcation, we were planning a provisional stending strategy, and she's already on dual antiplatelets with aspirin and clopidogrel, and she's well hydrated in view of the renal dysfunction. Next. So can you see the angio? These are AVA films. We'll show the proper angio afterwards. Can we go to the next one? This is the RCA shot. Proximal RCA critical. Next. Next, please. This RCA, we are planning to extend into the PDA with the provisional stending strategy. Next. And the circ looked a bit more complex lesion. There are two bifurcations. The distal circ in the AV groove is a biggish vessel, but the OM is a major branch which bifurcates daily, and there's a true bifurcation lesion there, Medina 111, and both the branches are almost equal size. Maybe the lower branch is a bit bigger in size. Next. So this is the AVI picture from the previous angiogram. Is it clear there?
Yeah.
Okay. So we have two bifurcations there. The proximal circ is tight. Proximal OM is tight. Then the true bifurcation, and the lower division shows a little more disease. Longer segment has disease.
and almost same size 2 branches distal. Now, what would be strategy for this particular lesion, the OIM lesion? We were doing the OIM first. Since this is a distal OIM with two true bifurcation lesions, we thought we'll do strategy. We didn't want to put 2 stents in the OIM, however large it is. The LCX into the lower division of the OM and wait and see how the first division of the OM behaves. Next. Thank you. So now we'll go to the work we have done. We started a bit early actually. Can you have the screen, please? Yeah, and you. So, yeah. So to our surprise, when we did the first angiogram today, the vessel has already occluded. At the OM origin, it had occluded. Next. Next. So we didn't have much difficulty in crossing that. There is a recent occlusion, but the lesion had progressed a little bit. Next. Next. We crossed with the fielder XT into the upper branch. Next. Next. Exchange for a 7 blue. And then dilated the proximal segment of the OM with a 1.5 mm balloon. Next. 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 Go forward. This allowed us access to the lower division of the OM using another fielder XT wire. Next. And dilated the proximal portion of the OM with a 2 mm balloon. Next. Next. Yes. Now we have this picture, almost equally sized branches. Go forward. Dilated with a slightly bigger balloon to 0.2512. Also, next. Next. So there is a lot of dissection there, and lower division of OM has more dissection, and upper division looks better with no significant dissection there and minimal lesion there, minimal stenosis there. So we thought we'll go according to our plan, but before that we did an OCT. Can we have the OCT, please? So the OCT showed smallish caliber vessels, basically about 2.25 vessel display, and bifurcation. At the bifurcation looked there's a bifurcation there. So go back. Bifurcation looked very well open the other OM. So we thought we'll go according to our plan, and there was a lot of fibrous plaque and lot of dissection there. Come back. That's the main LCH. Three vessel there. Next. Next anterior here. So we directed the proximal OM again. And next go forward. Yeah. So this is a 2.5 into 38 mm stent. Forward. Forward. Okay. So the angio, please. Yeah. Okay. 2.5 38 mm signs. Next. Next. And the first division is still flowing reasonably well. Symmetry flow there. So we did a port with 275 into 8 mm balloon. Forward. and use the third wire to recross into the side branch. Forward. Yeah. The other wire was pulled out without much difficulty and direct the entire vessel with 2.5, the entire stent with 2.5 mm. Go forward. There is a residual stenosis there. We went to very high pressures and it partially yielded. Forward. Now we have an angle here. Go forward. Direct weight. Dilated side branch with a 1.5 mm again. Now we did OCT here. OCT. Can you see the OCT on screen?
Yeah.
Yeah, we can.
Okay. So basically the stent has come up well, and we have the bifurcation. The first bifurcation here, which is yeah. So that vessel looks well opened there. Side branch.
What was the size of the stent?
It's 2.5 into 38.
It seems that distal to the bifurcation, the stent remains underexpanded in the OM.
Immediately distal to the bifurcation.
Yeah.
It was dilated to high pressures with a 2.5 mm balloon, but I think the vessel size may be something just about 2.5.
See, around the 20 mark, I think the vessel is not fully expanded.
That's right.
Yeah.
Yes, so I think I would,
15 and 25.
yes, so I would probably take a OPN balloon at this stage and go high pressure. I think that's a clear option at this stage.
Yeah, actually there was a calcification at that particular area where.
Yeah, in that OCT, we can clearly see that. Yeah.
That lesion was very hard to cross even with the balloon initially. We took a 1.5 balloon and then sealed it direct with the 2.25 earlier before stent placement.
Dr. Hiramat, underexpanded stent with underneath you get calcium. What about the role of IVL?
Yeah, but IVL probably pre-stent would have been a better option. But at this stage, when the stent is already placed and you see a lot of resistance for the non-compliant balloon to fully expand the stent, I would probably take a OPN balloon and go ahead.
Yes, because that is one of the situation where IVL is being tried now, under expanded stent with plenty of calcium. So it will act onto the calcium through the stent struts. That is one.
Yeah, there is also an issue here where those pulses which come from the IVL balloon, whether they would hurt the polymer of the stent.
That is there.
Okay. Regarding the side branch ostium, would anybody suggest an Ffr?
Can you show us the 3D on the side branch again on OCT? I mean, we have to understand that it's a big branch. Probably the distribution between the two OM branches is 50-50. So we have to do something. I would definitely do a DEB on the side branch because there was an important lesion at the origin of the side branch. We have balloon dilated it. So even if it doesn't look bad at this stage, the possibility of ballooned intima at this stage would attract a high restenosis rate. So I would, if you don't want to put a stent, I would put a DB into the upper branch at this stage. Actually, my own feeling was we should do with two stent strategy. The first stent would be in the lower OM, and the second one can be going from circumflex to the upper OM, do a mini crush and do a final kiss. So that would have been my strategy, considering both the vessels are quite important. And then you are dealing with an ACS kind of situation. The previous angio showed a flow. The first picture today showed no flow. So obviously there is a thrombotic process which is going on. So it is better to have stent under these kind of settings, though, I mean, cannot be handled as a standard cold stable bifurcation. You have to add the component of instability and possible thrombus at this site.
So now, since Dr. Jayesh has raised the question of FFR in the side branch, just had couple of doubts regarding that. We heard that Dr. Praveen Chandra has told that jailing an FFR wire is not a major issue at all. Is that the opinion of the moderators and the expert panel over here? Because we have had situations when we tried doing an FFR of the side branch through the stent cells. Twice we had a situation wherein we were not able to even pull out the FFR wire from the side branch. We had to take in a balloon over the wire, over the FFR wire, go through the cells distally, and then take out the FFR wire from the side branch. So this happened twice for us. So is that a safe thing to jail the FFR wire? I personally felt that one should never jail the FFR wire. And secondly, while doing an FFR of the side branch, is it always good to go over a microcatheter into the side branch and pull it over the microcatheter? What's the general opinion?
I think
so it's an interesting question. There is some data on this, and that's that there's a series from Japan where they've used the Opsons pressure wire, which is a fiber optic pressure wire. And I think it's something like 50 or 100 cases where they did jailed FFR measurements and then pulled the wires out, and they had no issues with that series. And then also at EuroPCR, we presented some data looking at jailing, again, the Opsons wire in a benchtop model and showing that looking at them actually under microscopes after we removed the wires to look for structural damage to it, and also the amount of force that it took to remove the wires. And there didn't see any issues. Personally, in my own practice, I uncommonly jail it. It's not that I never do, but since I've seen the Japanese data and then our own benchtop stuff, I've become more willing to do it. But I must say, cases where you're at a bifurcation where there's a lot of calcium or strong angulations, or you think you might pin the wire with a stent, those are the cases where I would still be cautious about it for all the reasons you mentioned, Dr. Davis, and the concern that it's going to be very difficult to remove that wire afterwards.
Also, you're going to jail the side branch wire, Dr. Deepak. You should not do part before you withdraw the wire. I think the more help is going to come after we do the part. How much is the side branch pinching, etc. So I think it's a little bit superfluous putting a side branch wire, jailing it. So even if you jail it, before you do the part, I think the wire must come out. So which again loses the whole exercise, importance of the exercise in trapping the side branch wire. So I wouldn't do it.
Yeah, I with the currently available wires, I wouldn't do that. Probably the wire Opsons wire or newer generation of wire one, maybe even more. But with the currently available wire, one should not jail the wire.
Especially the first generation wires, you should never jail. Especially the first generation wire, which is available with the that is radifocus, that is Certus wire, that you should not jail. Only the I think all the data with the Japanese data, all with the new generation wires, which may be probably
all Opsons, right?
All are low profile wires, which have no, which are more user friendly. But old generation wires, I think you should never, because there have been instances where the wire broke between that the junction where the transducer is connected, and it gets embolized in the side branch.
And crossing the stent struts also not always required a microcatheter support unless you have some tortuosity proximal in the vessel. Otherwise, if the stents, the main vessel stents are deployed well, and after giving a port, you could assess the site transfer by the wire on the stent strut without the support of a microcatheter.
So actually we crossed the exchange with a microcatheter today.
Yeah.
To the Ffr wires, but then there was a problem with equalization of pressures. How do you equalize?
Yes, sir, very true. Equalization of pressures is a challenge. Even looking for the drift is also a challenge when we want to withdraw it over the microcatheter.
No. When you use microcatheter, keep the light on. When you can disconnect at the back end, but make sure that the light is kept on. And over that, you can remove the microcatheter and put it back again. So I think that's a trick we must understand. The transducer outside should have the green light on all the time.
No, sir, you have the microcatheter going into the vessel, you know. So at that point of time, equalization will be a challenge. Similarly, while taking it out, also you are removing the wire over the microcatheter. So again, looking for the drift also will be difficult.
I think you can you take the wire directly, more try it. If it is not going, then you can go for an
So,
Back to the case.
yeah. So after this, we did a kissing inflation of bifurcation with robot.
What was your FFR, Jayesh?
We did a kissing inflation and then with the Ffr. I mean, Ffr is ready now. Yeah. Next. So I put a microcatheter and exchange, but there was an error on the Ffr system because it was showing baseline 0.81. So I took the wire back and equalized again, and then went back in with minimal support of microcatheter. And now we are all set for the Ffr. Now the baseline value is 0.92. So the Ffr screen. Can you see the Ffr screen?
Yeah.
So now we are ready to give adenosine. We have only intracoronary adenosine plan.
I mean, we all discussed just now that intracoronary and intravenous, probably there is not too much difference. The intracoronary, however, you're quicker. You could just give bolus and you come out. While intravenous, you need to go for a long time. So critical cases where time is an issue, time is a factor in decision making, I think I give intracoronary and not intravenous. But I guess the guide catheter tip position is very important when you're giving intracoronary adenosine.
So I'm giving adenosine.
Dr. Niels, at this point of time, we are seeing that the PDPA was more than 1.0102. What could be the reason for that? It said that in circumflex artery, you can have a distal pressure more than the proximal pressure. Is that a common finding?
I think in this particular case, if I was watching the tracings correctly, they only just now came back on the aortic pressure tracing. Yeah. So I think there was a screen or two where they were open and were preparing the intracoronary adenosine for injection. And that I think is a drawback. The systems will continue to give you numbers even if your aortic stopcock is open, and those shouldn't be paid attention to until you're back on pressure.
They're on intravenous adenosine, aren't they?
So the value is 0.92.
Was a bolus just given then of intracoronary adenosine? Is that what happened?
It was 200 adenosine, and it's 0.92. 90. So, any suggestions now? Like, shall we leave the sidebranch alone?
Yeah,
Yeah, you got an FFR of 0.92, is it?
Yeah, 0.92.
That means it's not ischemic, and you have not found any obvious dissections are also there. So probably you could leave that straight branch as such.
So our OCT showed some malposition at the proximal OCT.
Dr. Neil, this side branch FFR, today it is okay, 0.92. However, what about recoil? I think in early balloon days, you remember that every time you ballooned, there used to be a recoil which may be seen on table, it may be seen a few hours later, it may be seen the next day. So that recoil cannot be predicted by what we are doing just now. So what's your take on this recoil which would come tomorrow?
It's a good question, and there has been some data out of Korea looking at the long-term changes in side branch FFR after you deferred a bifurcation. And that data set looked at left main LAD circumflex. So these were circumflexes that were not treated after crossover left main LAD stenting. And they found that very few of these, even over time, remodel or recoil in such a way as to cause problems. And that's when you're dealing with the Osteocircumplex lesion. Here we've got a OM bifurcation. One of the branches supplies half and the other half, but the total amount of myocardium supplied by each side branch is much more modest. And so here, if your goal is to try to avoid side branch treatment using FFR, I think it's quite reasonable. And even if the 9.2 changed a little bit to 8.8 or something like that, which would be a large change, that's still well away from any threshold. So I think that it's so high in this particular case, it seems reasonable to me to leave the side branch alone from further treatment.
Aren't our two stent strategies getting better and better with the current stents and things like that? So what used to be provisional in, say, 10 years back for me, about 50% of them I have moved to a two-stent strategy. I mean, to address this balloon restenosis after, say, 2 years would be far more difficult than addressing it today. Towards doing two-stent strategy compared to what it used to be earlier.
Yeah, I must say, looking at this angiogram myself at the beginning too, I would have probably been more inclined to a two-stent strategy up front. But I think if you are going to pursue a provisional strategy, the data that we've seen so far during this case suggests that we should leave the other OM branch alone now that that's been the path that's taken. It's not as if there's a flow limiting dissection or low FFR in that side branch.
Did you do a drug balloon on the side branch?
So unfortunately, in the United States, we don't have drug-eluting balloons for the coronary arteries yet, as crazy as that sounds. I used them when I was in the Netherlands, and I think that's a reasonable strategy, but that's not technology we have access to in the United States at the moment.